Hello, my name is Jan Lathan.
And I am Muskan Joshi.
Welcome to MedNews Week Conference, where we feature presentations by medicine's global leaders. Today we have an amazing keynote speaker in Dr. Scott Tagawa. Dr. Tagawa is the medical director of the Genitourinary Oncology Research Program, the associate director of the clinical research in the Division of Hematology and Medical Oncology, leader of the Genitourinary Disease Management Team, and co-leader of the Experimental Therapeutics Program at the Meyer Cancer Center at New York Presbyterian Weill Cornell Medical Center.
In today's presentation, Dr. Tagawa discusses the latest updates in the treatment of prostate cancer.
Did you know that Dr. Tagawa led the first ever in-human work that led to the development of PSMA-targeted alpha emitter AC-J591, a PSMA-targeted copper agent, and the PSMA antibody-drug conjugate, along with leading the phase 1 and 2 clinical studies that resulted in the accelerated approval of sacituzumab govitecan for refractory advanced urothelial carcinoma, followed by the confirmatory phase 3 clinical study?
He is a true inspiration in the field of medicine.
So let's tune in and learn from this global leader.
So what is PSMA? I have Skip Heston, who discovered the gene, and Neil Bander, who really developed the first antibody that was shown to have some utility in the clinic. And this is a quote from Neil Bander: PSMA is the single most well-established prostate-restricted cell membrane target known. What does that mean? Well-established means it's not just in the lab, but also validated in humans in the clinic. Prostate-restricted, meaning it's there in prostate, and prostate cancer, not a lot of other places in the body, which is why we can really target that. I do see here mostly here. There's some other areas in the body that are important for those of you that are physicians or researchers to know. And it's on the cell membrane. As I point out for people, I'm assuming that you can see me. If this is a cell, PSA, we know what that is. It's made inside the cell, it comes out. PSMA, the extra M, is stuck to the cell. So it's only that's there. And it's a target of interest. It happens to be on other tumors as well, as I'm going to come back to the neovasculature. So taking a step back, I'm going to talk about PSMA, but this is a cell surface target, which I often use the example of a lock. So it's a lock that's very specific. The body is a hotel, and there's going to be one lock on one room that one key is going to work for. So if one went through every single door, the right key going to get there. So if that lock is only on prostate cancer, there's a number of different applications. So we can attach radioisotope drug imaging, there are particles, there's more that we can do, but this is an example. We inject it, it goes throughout the body, and that key takes in whatever we attach to it. In this case, it finds that lock, enters that door, and lights up that cell. This is a picture of a bone scan, but the same type of an approach. Inject something that we'll call that key. It's attached something that lights up. It goes throughout the body. It only lands in certain areas. So this is a cartoon example, but it does demonstrate the specificity. So these are areas of tumor, all these dark areas, and all the areas of tumor light up. There are other areas that are in the body. These are risks that are arthritis that lights up on a bone scan. The specificity you can see here doesn't light up there. So our colleagues at the Prostate Cancer Foundation recently published this long history of PSMA. And you can see here that the first imaging agent didn't work that well clinically, but I think it was important to kind of start the field moving back in 1996. And it took all this time. We have the approvals in the last year and a half or so. In terms of imaging agents, there are dozens that are out there that have been used in humans. But the two main ones that we have as part of standard care in the United States are similar. These are their names and nicknames. And they're, from my perspective, basically the same. There may be some out there that are coming that are a little bit different, but for right now, they're more or less the same. And those are just some examples. All the physicians have seen this, but when there's a little bit we can see, we can generally see more. And when we can't see anything, these PET scans really bring this out. The initial indications were really here, at least by the label, and this is where some of the major benefit was. So walk in the door, diagnosis of prostate cancer, is only my prostate or not, is not 100%, but it's the best we have and a lot better than we had before. So it sometimes doesn't change the initial approach, but I do think it's good to know. Knowledge, I think, is useful. Do we see something outside the prostate or not? And then we act accordingly. We're treated, PSA goes up. Can we find where it's coming from? Answer is yes, much of the time. Does that change how long a man's going to live? Don't know yet, but it does answer some questions, and I think influences treatment. And then the most recent indication was, we're going to get to, target prediction. I think there's a lot that we can learn kind of in between, and some of us are working on some guidance on kind of how to do that. So across tumor types, we do a picture, we see one spot, we treat that spot. So it's what we call metastasis-directed therapy. There may be some benefit to it, although in prostate cancer and most other cancers, we don't fully know how much that is a major benefit in terms of like how long does someone live. That being said, what I do believe that's important, if that practice is going to be done, I think we need to use the best imaging modality. So you can see here, if someone had these top two lines, had metastasis-directed therapy and got all the areas on the PET, they do much better than if they use some other less sensitive imaging agent and PET scan showed these other things, but they only use the other types of imaging. So I do think it's best to use a sensitive imaging agent if we're going to have a practice. Sorry, duplicate slide, but going back to PSMA, biologically, there's a relationship with the hormone pathway. And what we thought initially, so based on the initial publications, PSMA is always there 100% of the time when we do pathology studies. I just mentioned the most sensitive imaging that we have shows this, months or years before other imaging modalities a lot of the time. So it seems like it's always there, but that's not necessarily true. There's intra and intratumoral heterogeneity, meaning that an individual tumor might have some areas that have PSMA and some others don't, and some entire tumors may not have it. But it is there most of the time. Now, going into kind of the kind of prime time area that has happened this year, using this to help people in terms of treatment. So radiation has been used for a very long time for many cancers. It cures men with, certainly some men with prostate cancer, either by shooting in or putting in. It also palliates, meaning if there's some area that's causing a problem, make people feel better. And we can give radioisotopes that we're really going to talk about, directed to bone or directed to PSMA, that make people live longer. So what is PSMA-TRT? And you can broaden this and eliminate the PSMA and put in a different target there. But basically what we're talking about is giving a radioactive particle, putting it into the blood. It circulates around because it's carried by something, one of these keys, if you will, to the right lock, to treat that. And that's usually with a beta or an alpha emitter. There's also Auger, as well as we can see the gamma or PET for imaging. And there's different properties that we're going to talk about. And then there's different, that has to do with alpha and beta that we're talking about. And there's different carriers we're going to get to. So this is a partial list. This is really just, I didn't mean this as this, but this is a list of drugs that's been used in New York, which is true, but they've been used around the world as well. 3 of which have been used in phase 3, ongoing phase 3 trials. The way that this field started was with a number of different, we call anecdotes. And these are some anecdotes from here that you can see a lot, get some treatment, does better. Even when someone's already had one, gets another one and does better. There are a lot of different publications. I do not mean to disparage any of these. I think there's very important work that's done by very smart people, but just one example of what at the time I think was considered one of the best publications. 145 men, 12 centers, very experienced centers over 18 months, got novel therapy. But just to show the kind of drawback of these retrospective looks, we don't have the ability to look at safety if we don't have all the data. And 145 men, only 2/3 of them had a PSA to look at after therapy. So an important start, but our first presented and published prospective data came from Australia, which was very nice. And then 2019, I was very happy to say we finally completed 2 randomized prospective trials. And then 2022, this is now prime time. So these both were presented and published in 2021. And I think most of you are aware of this, or at least many of you are aware of this. The same drug led to overall survival, or as well as a delay in time to cancer getting worse on scans or dying. And then head-to-head against chemotherapy in selected patients, more reductions in PSA, as well as a number of different other secondary outcomes. Nothing is for free. All of our drugs, and not just drugs, all of our treatments have some possibility of side effects, and to point these out. So some constitutional, so there can be some fatigue with these therapies. There can be some effect on the blood counts. Usually these are what we call low grade and temporary. PSMA, as we'll get to, is expressed in other organs. So these are what we can call on target, meaning to PSMA, but just not on the tumor, so dry mouth as well as nausea. There can be, at least in theory, some effects on the kidney, but luckily, that at least so far, that has not looked to be anything significant. But we're looking at that, as well as could there be cancers down the line. These do not appear related. These almost all happen within months of starting the treatment. Despite having more side effects, and part of those side effects, as we learned from a presentation several months ago, are appear to be more because we are following the patients for longer. But that being said, and this is true of many of our treatments, including chemotherapy, that the time to feeling worse, these are quality of life scores, other time to developing pain, is much better, even with the treatment that has more side effects. So the way I like to say this in the clinic, the side effects of untreated or poorly treated cancer are much worse than the side effects of effective therapy. Different types of carrier vehicles. I started off showing you kind of in reverse order. So the small molecule, actually antibodies started this field, and this is Neil Bander's antibody that showed it could be administered human safely, and then phase 1 trials with the targeted radionuclide, then initial phase 2s that showed, oh, there's actually maybe some responses. We changed the way we do it, we split it in half or fractionate the dose, and that looks to be a little more safe. Expanded that phase 2 study to kind of make some confirmations and show some dose response. That fractionated version, meaning splitting the dose, was safer, so we could actually combine it with concurrent chemotherapy. And then that fractionated dose was expanded into a phase 2. And the summary of all that was that in unselected patients, so all these patients were imaged, but that was not used for selection. Overall, there's accurate targeting, tolerability with blood counts that come down and then come back up. And then that fractionated dose looks to be the most effective. So that is now in a phase 3 trial. But there is this myelosuppression. So we need to figure out the kind of risk benefit and how to select patients. So where do we go from here? Academically, many of us are looking to optimize the dose and schedule of these small molecules. The patient population, I'm going to talk a little bit about mostly in terms of imaging, but there are likely some clinical factors, some genomic factors that I mentioned before that I don't think I have slides on them, but there's early data to say certain things like P53 looks like these are less likely to benefit, and things like maybe BRCA2 that they're more likely to benefit, but that's early days. And I think this year we're going to have more data on that. One simple way of doing this is to move this forward. So rather than wait until there are maybe more of these resistance patterns with the cancer and maybe less PSMA, move it up. So this is in a similar disease state, meaning there's been growth of castration resistance despite low levels of testosterone, but before chemo. So there are 4 phase 3 trials with 3 different agents in that disease state. And then in the initial non-castrate, so men walking the door of metastatic disease in combination with hormonal therapy or sequentially with chemotherapy, 2 different randomized trials, 1 phase 2, 1 phase 3. I'm not going to have time to talk about so many combinations of one slide, and then I'm going to talk about more potent agents. So for the clinicians that are in the audience, I think you've had a chance to read the Lancet and the New England Journal publications, but just in case you didn't at a high level, Vision was designed for patients that have had literally everything. So if they were eligible for radium, if they're eligible for PARP, they should have got it. But the minimum, they had at least 1 AR pathway inhibitor and 1 chemotherapy. Therapy required only prior docetaxel, although not more than 90% also had at least 1 AR pathway inhibitor. Also required a high PSA to get in because it had PSA endpoints. What I want to point out is that there was imaging selection. So on a low level, on the Vision study, 19 out of 20 had a positive PSMA PET, but 8.7% also, besides having some positivity in tumor, had some tumors that were negative, so they were excluded. So overall, about 87 met these criteria. It's much more strict criteria with dual PET imaging on the therapy study, and more than double didn't qualify for the treatment based on these imaging agents. So what do I think about that? I think that there's pretty good data for trials for patient populations using these small molecules with beta emitters, and some data with the antibody as well, at least with the beta, that we improve the therapeutic ratio, meaning the patients are more likely to benefit when they have positive imaging. But we also know that patients with absolutely 0 uptake can still respond. So I think it depends on the situation. If there's literally no other options, maybe something that can be tried. Imaging has the advantage versus the biopsy or a blood test. We can look at each tumor individually. This is only assessment at a period of time. And, I do think that this does bring in the possibility of response assessment that we have not had in prostate cancer. Unmet need, we have 2 radionuclides, only a fraction respond. I think at a very, very high level, this comes down to 2 factors: dose and tumor/host characteristics. So dose has to do with how much are we squirting in, so what's the radioactive dose, plus uptake and retention. So there's many different factors that come down. That goes to dose. How much radiation is getting to the tumor? Has to do a little bit with how much PSMA is there, but also how much is kept in there. And then aspects of the patient. So these are areas that we are working on actively. I mentioned there are different carrier agents. I showed you some of the different data with these when they had lutetium on it. Based on their properties, we would expect to have different outcomes in terms of side effects. You can see here, this is data from my colleague in New York at Memorial Kettering, Nita Panetasker, and some data from Germany, that the large ones circulate over days, small ones over hours, and land in different places, including pretty much all of the PSMA positive areas with the small molecule, but the antibody are too large to get there. We hypothesize that something that floats around in the blood for a long time is going to lead to more blood count drops. Something that's small enough to get into the salivary glands or the intestines can have more nausea and dry mouth, and that turned out to be true. Another way of saying this on the lay part is the large versus small keys might lead to differences in side effects. Alphas and betas is a very simplistic cartoon here. Forgot to to get one from my colleague Joe Thorne that has a little bit more sophistication, but basically alphas are very powerful, but can't travel. They can't penetrate even a piece of paper. Versus the betas, much less powerful per particle, but depending on which one, can go through tissue, bone, depending on what is which one it is. Cartoon example. Tumor that's there. Think of a long range one. Well, the nice thing is that targets this area. If this area doesn't have PSMA on it, we can hit that with crossfire. But maybe it's getting a little bit too much in terms of side effects. Versus something that is shorter range is going to get that area just right around it, but is going to miss the other area. So there's advantages and disadvantages. One of the interesting aspects that we've looked at is what if we combine them? You know, so they go to different areas in the body, but they both land in tumor. So maybe we could back off the doses of each one, put them together, and have much more of a response with less side effects. That was the thought process when we started this. And the first thing was, well, can we give them? Did they block each other? They at least this antibody binds to a different place than the ligand. And then when you give them together, you can look at the two blues adding up or the two reds adding up. It's additive. They are non-competitive. So then that led to experiments that we gave radiolabeled with lutetium both. And we saw something very interesting. This is what gets to the tumor when we combine them, actually each one of these, each one alone. And you can see much more uptake with the antibody, but ignoring that, what happens when we give them both is much more than giving them alone. So for some reason, there's synergistic uptake. There's just more that is there. So we wanted to figure that out a little bit. And you know, their ongoing experience, and this is presented at ACR a couple months ago, but it has to do with what happens to the small molecule alone or in presence of the antibody. So the small molecule alone binds PSMA, gets into the cell, and then is spit back out when the pH drops, basically. You can see the more sophisticated explanation here. However, when the antibody is given, the antibody is also bound to PSMA. That entire group is driven into the lysosome, and basically it stays within the cell. So just by giving the antibody alone, we can get more lutetium in via a small molecule like PSMA-617. So interesting things that we're looking at. Alphas and betas, I showed you kind of differences. Some very impressive pictures. Patient was treated with many different agents. It's a cancer all over, PSA of nearly 3,000, wiped out. These were amazing, are amazing examples. Say were because you can see when this was first published. And then, you know, combined work between Germany and South Africa, working out some of this, you know, the best that can be done in the situation, particularly in South Africa when there's not a lot else. But they do have expertise in nuclear medicine. So, you know, figure this out prior to official clinical trials. You know, another example, but, you know, one of the things that you can look at here is not just wiping out tumors, wiping out salivary glands. So there can be some toxicity. So finally, this led to prospective clinical trials. This happened to be an alpha that's called actinium-225. So one of the very potent agents that can't penetrate much using the antibodies. So antibodies are big enough they can't get in salivary glands. So patients that had not really other options did not have to have PSMA positivity, although we scanned everyone that we could, and did increasing doses. As it turned out, that highest dose did not have major toxicity. So we just decided it's not practical to go up higher. We're going to just look at more patients at this dose. You can see here, despite not selecting for PSMA by PET, and despite about 4 out of 10 having prior lutetium PSMA, there's still PSA declines, and at least an initial look the same whether they had prior lutetium PSMA or not. So interesting, and PSMA targeted as well as other cell surface targets are of high interest for alpha emitters. So this was the first study. There are a number of different studies away with this particular compound, either alone or in combination. The second agent, not coincidentally to go into humans prospectively, happened to be an antibody, but small molecules are now there, and there's others that are on the way. All of what I said, or most of what I said, vision was not given as a single agent necessarily, but they were all designed as kind of single agent studies. There are different combinations that have been done. So 2 have been published with a number that are ongoing. Combinations with chemotherapy, combinations with radiosensitizers, combinations with PARP inhibitors, different hormonal agents, and with different PSMA agents. So this is a small fraction of what's going on with combinations. But I do believe that we're going to make some of the biggest inroads looking at combination therapy. One type of combination therapy that's of interest, and this is from last week at ASCO, is combination with immunotherapy. So immune checkpoint inhibitors, we know multiple experiments. We give them to a mouse with radiation versus without radiation, we cure much more. So it's called abscopal effect. We can generate an immune response in a different place than we're radiating. Well, why don't we radiate most or all the areas with mutation PSMA-617? So this is an experiment in humans, a clinical trial, where everyone got kind of full doses, higher than what we give, kind of vision, at least initially, radioactivity levels, selected by PSMA with immune checkpoint inhibitor called pembrolizumab. PSA decline rate's pretty good, with an updated slide compared to when we saw this last year at ESMO. There are some patients that are more out here, although most have had some progression, but not every bar has had some progression. So the question is, are we going to be able to have durable responses or cures with this combination? We shall see. Another same combination, but it's another way of looking at it is, just like we do with other examples, shoot in some radiation once or 3 times, small point in time, and then give it with the immune checkpoint inhibitor, let it go. And that's what our colleagues at UCSF have done. This is just the phase 1 part. We'll see what happens, but there may be something that is happening there, early days. And then this is a 2 versus 3 combination. You can see the rationale here, but basically this part is now done. We're currently actively doing this summer, and then in the summer, it's going to be a randomized trial of having PSMA-targeted radiation or not. Thank you, supported by you all, U.S. tax. Well, this is worldwide. This is the U.S. taxpayers from the Department of Defense. I don't expect you to be able to read this. This is a partial list, but there are a lot of different clinical trials that are going on in different disease states, either alone or in combination. I'm being U.S.-centric right now. All those are with arrows are enrolling within the United States right now. So these are available, many different places around the country. Now, that lock or the target on the cell, we can put in a key, but we can attach things besides radiation. Antibody-drug conjugates are very common these days, and we can target PSMA. This is the current modern version that had the initial study presented at AACR a couple of months ago and is ongoing. Other ones are coming. The immune system, I mentioned. This is either some mechanism to get T cells to PSMA-positive areas, or have some sort of immune activator, or what we call CAR T cells, engineer cells to usually coming from the patient and then giving them back, have them go in as CAR T cells to really, hopefully, wipe out prostate cancer. We don't know, but these have moved into humans over the last number of years. These are 2 called the bispecifics or BiTEs. This one's a little bit further ahead, but they're very similar, targeting PSMA on one end, pulling a T cell on the other end. We see PSA declines, we see CTC count declines, And there's a subset. These are started later, so they can't get out here faster. Same thing here, but there's a subset that are going past 6 months. Are they going to go years? We shall see. So lutetium PSMA-617 has been approved for now little less than 3 months, 2.5 months, something like that. General hemoncs, internists are going to see this. What to expect? Well, because PSMA is in the salivary glands, expect to see some dry mouth. Beta emitters, lutetium PSMA-617 is not that potent. So usually you'll see a little bit of damage, not that big a deal. After talking for the last, however long I've been talking, I have a little bit of dry mouth, but I'll take a sip and I'll get better. So that type of a thing. Blood counts can come down. It's a little bit different than chemotherapy. Rather than being maybe a week later, we're talking several weeks later, but then usually back up and usually low grade, but I'm saying usually because there are cases. General things like fatigue that might happen with radiation. Nausea might be on target in terms of PSMA to the intestine, and there can be pain flares. These are things that, if they're going to happen, most often happen at the beginning of week 1, and they get better with time. We do not have long-term data. So I have individual patients that are out more than 10 years, but it's a very small number that are out even 3 years because it's new. And unfortunately, patients at this stage don't necessarily live that long. But we have a number of different trials looking for long-term survival, or some are even looking for cure. And we'll see what happens long-term. Some of these agents, particularly those have gamma, like lutetium 177. Gamma is what we see like a bone scan. Those are things, gamma rays can shoot through different agents. Unless there's lead, it can kind of shoot through things. And so the closer you are, the more that you're going to get. So this can affect healthcare workers, family, friends, etc. The key is the closer it is time-wise to the treatment, and the closer the other person is, and the longer that's there, the more it could be there. So hugging, not a big deal. Sitting on someone's lap for minutes, probably not a big deal. Hours, especially the day of treatment, may be a big deal. So just kind of keep that in mind. So in summary, PSMA is clinically validated. It's fairly consistent as a cell surface target. It is relevant in the current era with all of these other therapies. We can target it with antibodies or small molecules. Prostate cancer rate is sensitive with a dose response, so hopefully we can optimize the dose. We can exploit the selectivity of PSMA expression to deliver high doses of drugs or radionuclides with relative sparing to other organs. Can we cure? There's heterogeneity that's there. So I don't think it's going to happen as a single agent, but what about combinations? I think that is possible, particularly if we pre-select the optimal patient and our patient population with a number of different tools that we have. Beyond prostate cancer, beyond PSMA. So PSMA is expressed on the neovasculature of virtually every other solid tumor, at least all the other carcinomas, but not in their corresponding organs. For instance, it's on lung cancer, but not in lung. And we may be able to use radionuclides or drugs to target it. PSMA is just one example of that lung cell surface target. So pick another one, and in prostate cancer or other ones, take these same principles, which is now validated, and hopefully we can exploit them. The most common way that's being done across different diseases is antibody-drug conjugates, but I do think that there is likely a place for bispecifics as well as CARs in development, as well as targeted radionuclide. And targeted radionuclides as a theranostic pair, meaning see what you treat, it's one way of having an in vivo test. Patient, as his or her own example, in real time, we inject something, lights up, all the tumors light up, that may be a good target in that individual. Even if 9 out of 10 light up for a specific tumor and target, that individual doesn't light up, maybe not the best choice unless there are no other options. So I do think that theranostics as a field has some advantages. I always like to end, I'll have one more slide after this, with those of you that have prostate cancer, know people with prostate cancer. I'm going back to this clinical state. We're talking about, death from other causes, death from prostate cancer. Let's talk about life. So you want to live your life, no matter if you're here, like you're at risk, like me, could I get prostate cancer, or are diagnosed with prostate cancer? Live your life. Don't put your head in the sand. There's a lot of good treatment options, but we want to maintain length of life as well as quality of life. So a number of discoveries in the clinic have come back to lab and lab into the clinic, and these are now clinically relevant. And it is great to be working in the GU Oncology Clinic today as compared to what was before, and I look forward to additional advances. That slide of many different people and subspecialties involved coming together. This is not I'm sure I left some very important people off this, unfortunately, but just an acknowledgement to all of the different collaborators here and elsewhere, funding from maybe some of you that are listening in, and especially to the patients and their families who participated in research here as well as others. So thank you very much.